Good morning. You are welcome back from the break. I'm presenting on the fixed-dose combination antiretroviral drugs. And we are saying that they have comparable immunological, virological, and adherent potentials with the single drug combination. Now, by way of introduction, antiretroviral therapy has destroyed coffin business in most African countries. Before the advent of antiretroviral therapy, you would know that the best business to do, if you were a businessman, is to sell coffins because of the rate that people were dying as a result of the infection. But today, because of the effectiveness of antiretroviral therapy, the situation has changed dramatically. Patients starting ARV are able to achieve sustained viral plasma viral load below 20 copies per liter. This is the situation we have now. Now, to improve the success of antiretroviral therapy, the World Health Organization, from time to time, they bring different policies and they make different recommendations to improve the practice. Now, in the current treatment guidelines, one of the recommendations there is that fixed-dose combination are classified, they are the preferred regimen over the single drug combination. That is to say that if you were a clinician and you are working in an antiretroviral clinic, you are more likely going to use fixed-dose combination rather than the single drugs. And the reason for this is very simple. The FDC have fewer pills, and therefore they are thought to promote adherence to antiretroviral therapy. You know that antiretroviral therapy is very, very critical to the success of ART. So the fixed dose, since the pill burden is less, they are preferred. So because of this policy that the World Health has made, in most countries, they have completely deleted the single drug molecule from the formulary. In fact, in Nigeria, you may not find single drugs anymore. All that we have are the FDCs. But we've started seeing problem with that. One of the problems is polypharmacy. And of course, polypharmacy will lead to more drug interaction and additive toxicity. So because of that, we now decided that we should investigate whether the FDC have superior adherence effect and virologic suppression, because the only reason why the FDC are preferred is based on the fact that they have a superior adherence potential than the fixed-dose combination. So we wanted to investigate that. So we conducted this study in the largest antiretroviral treatment center in the North Central, which is the University of Abuja Teaching Hospital. Now, we included 501 people who were living with HIV. So those patients, they were either prescribed a fixed dose or a single drug. Now, those of them that you could see the fixed dose, these are the likely, sorry, the pointer is not okay. Either this or this, and if you are taking any of this combination, you'll be taking about 2 pills daily. So you have only 2 pills to take. But for the fixed single drug, these are the likely combinations you could have, and you end up taking 8 pills daily. So the argument is somebody that is taking 2 pills should actually do better than somebody that is taking 8 pills. This is why the FDCs were removed. Now, we define adherence as taking at least 95% of medication in correct doses and frequency, while virologic suppression was defined as, we define it as achieving, if you're able to suppress the virus to this level, okay, you have achieved that. Now we use propensity score method to randomly assign the patient in the 2 groups, because our study was cross-sectional, And to address the effect of confounders, we use propensity score. Then we applied logistic regression in our analysis, and this was the result. You could see from this that patients that were using the single drugs and those that were using the fixed dose combination, there was really no any difference as far as adherence was concerned. There was no difference in the adherence. For the virologic suppression, the same thing. There was really no any difference. So we now begin to think that if this is the case, we do not have, at least in the cohort we use, we see that adherence and virologic suppression, we are not different. There was no any difference between the patients that were using the fixed dose and those that were using the single drug combination. The adherence, there was no difference. So if that is the case, it does not make any sense to remove the single drug combination from the ART formulary because of the problem that we have. We're using only the the fixed dose combination. If you are using the fixed dose, you will have problems in treating some of the patients. Patients with compromised kidney may not be able to use 300 milligram lamivudine. And in all the fixed dose combination, lamivudine is always in 300 milligram. So there is a problem. So based on our finding, we say that single drug should be retained alongside the FDC. We are not against the use of fixed dose combination, but you should also have the single drug alongside, so that in situations where you cannot use the FDC, you should have drugs to use. The clinicians have a lot of problems in dealing with some of these patients. Well, I've acknowledged I work with the Institute of Human Virology. They've given me this opportunity to do this work. And I also acknowledge Professor Ting for his outstanding work in pharmacodynamics and combination therapy. Our study has to do with combination therapy, and Professor William Blattner for reviewing and approving this work. Thank you.